Hello all, in this video we'll be discussing about coagulation failure in pregnancy. So we all know that pregnancy is a hypercoagulable state. So there are some changes that takes place in a woman's body during pregnancy that makes it a hypercoagulable state. So let's see what are they. So this include increase in coagulation factors such as factor 1, 2, 7, 8 and 12. But some other coagulation factors like factor 11, 13 and antithrombin 3 remain unchanged. But most of the coagulation factors increase during pregnancy. That is one of the important change. The next change is that there is decrease in fibrinolytic activity and also there is decreased platelet count. Why? Due to increased platelet consumption and aggregation. So all these changes, it makes pregnancy a hypercoagulable state. So there are many changes that takes place in a woman's body during pregnancy that include hematological change, cardiovascular system change. But whatever is the change, it takes place for a reason, right? So similarly, pregnancy is made a hypercoagulable state for a reason. So during the time of delivery and all, there is chance for increased blood loss. So it is to compensate for that, to avoid the excessive blood loss. Pregnancy is made this hypercoagulable. So in this lecture, we will be discussing about coagulation failure. That means any condition that affect or impair the hypercoagulable state. That is known as coagulation failure. So let's see in detail about it. So we can classify the coagulation failure in pregnancy into two types. That is inherited and acquired. Inherited include hemophilia A and B, then von Willebrand's disease. And acquired include disseminated intravascular coagulation, idiopathic thrombocytopenic purpura and anticoagulant therapy. So this can be asked as a short note question about coagulation failure in pregnancy. So first of all, you have to write the introduction, then we have to classify it, and now we can see in detail regarding each of it. First one is inherited, that include hemophilia. So hemophilia, there is two types, hemophilia A and hemophilia B. So you might have learned in your medical surgical classes regarding hemophilia. So hemophilia is a sex-linked recessive disorder. So it is commonly seen in males, and in females it is very rare, but also there are chances for it. So in females it is very rare. So first of all, about hemophilia A, it is due to the deficiency of factor 8. So factor 8 is a coagulation factor. It's a clotting factor that is necessary for clotting. So there is deficiency of factor 8. So you have to remember that none of these conditions are associated with pregnancy. So hemophilia, the woman will be having hemophilia from birth onwards. So antenatally itself, it is important to monitor the factor level. And if the factor level is in normal range, then there is no problem, there is no need for any treatment and all. But if that is not in normal range, that is if the clotting factors level is less, then we have to give some treatment. That is, we have to give the clotting factors externally. So that is the recombinant factor 8. We'll give the recombinant factor 8. Then another very important point that you have to keep in mind is desmopressin. So it is a synthetic analog of antidiuretic hormone. This desmopressin can be given for the treatment of this hemophilia A, because this hormone, it can increase the level of factor 8. So that is a treatment for hemophilia A if the level is less. If the level is normal, then there is no need for any treatment. The next, at the time of delivery, so antenatally itself, we have to administer the clotting factor. We have to give a desmopressin or the recombinant factor. And during the time of delivery, if the child is male, then we have to immediately send the cord blood and detect the level of factor 8, because this is a sex-linked disorder and males are having the more probability for getting the disease. So if it is a male child, we have to immediately send the blood sample, cord blood, to detect the level. And if the child is diagnosed with hemophilia, then immediately administer recombinant factor A, then avoid IM injections and give vitamin K injection orally. And after delivery, so there is chances for postnatal fall in factor 8 that can lead to severe postpartum hemorrhage. So along with this sending the baby's cord blood, we have to monitor the mother's factor 8 level after delivery. So to see if there is any postpartum fall in the levels. If there is a fall, we have to administer recombinant factor 8. So that is regarding hemophilia A. The next one is hemophilia B, that is caused due to the deficiency of factor 9. So it is similar to that of hemophilia A itself, and factor 9 levels do not increase during pregnancy. So hemophilia B carriers are more likely to require replacement. So in the beginning of the lecture, we have seen that factor 8 increases during pregnancy, but factor 9 remains same. So there is increased chance for replacement. So there is increased probability that the woman's condition can get worsened during pregnancy. So we have to need, there should be a need for the replacement of factor 9. So similar to hemophilia A, we give a recombinant factor 9 in this case, and also desmopressin can be used. Next one is von Willebrand's disease. So von Willebrand's disease is a disease that is caused due to the deficiency of von Willebrand's factor. And what is this von Willebrand's factor? It is a plasma protein that helps in the stabilization of factor 8, and also it helps in adherence of platelets to injured blood vessels. So this shows that this von Willebrand's factor is a very important plasma protein in the coagulation cascade. So in the milder forms of the disease, diagnosis is not required as it normalizes during pregnancy. If there is only a mild form of the disease, then there is no need for diagnosis. But in severe forms, there is a need for the replacement of the von Willebrand's factor. So similar to hemophilia, here also we are giving desmopressin. Okay, and during the time of delivery, we have to avoid episiotomy, then instrumental delivery and cesarean section. So this three things we have to avoid if the mother is having von Willebrand's disease. This is similar in the case of hemophilia also. We have to avoid all these things and perform this only for obstetrical reasons. Only in case of emergencies, we have to perform these things. Otherwise, there is a chance for increased bleeding. Lots of blood can be lost from the mother's body, and also avoid fetal blood sampling and vacuum delivery, because this is a genetic disease. So the baby may have the disease. So if we perform fetal blood sampling and vacuum delivery, there is an increased chance that the baby's condition also worsens. So we have to avoid all these things in case of von Willebrand's disease and also hemophilia A and B. So I hope this is clear. In the next lecture, we'll be discussing the remaining. Thank you.